So the AZALEA-TIMI 71 trial was a trial studying one of the novel factor 11 inhibitors, Abelacimab, which is a monoclonal antibody against factor 11, versus standard of care DOAC rivaroxaban in patients at moderate to high risk of stroke with atrial fibrillation. And the overall trial results was an impressive, 60 to 70% reduction in all types of bleeding with the both doses of Abelacimab, about 150 milligrams and 90 milligrams sub-Q monthly versus rivaroxaban. And in this analysis, what we wanted to look at was a subgroup of patients that physicians and also patients in the family themselves are concerned about, and that is the elderly. And for this analysis, we defined that as 75 years of older, but we looked patients who were 80 and older, 85 years and older, because we know this is generally a population where being on an anticoagulant is a big deal. They tend to have higher rates of bleeding. There's lots of undertreatment in this population in older individuals and a lot of discontinuation of current standard of care due to bleeding. So we think potentially for a drug that's far safer than anything we currently have, that this would be an ideal population where, if proven to be effective in phase 3 trials, a very safe anticoagulant would have a lot of appeal. You have to be a little bit careful in trials with differences in baseline characteristics because in order to qualify for a trial, you need to have certain factors. So sometimes if you took a general elderly population, it may not be as reflective as the clinical trial population. But some of these things sort of hold true. We know that older patients tend to often be thinner, have lower BMIs. Some of that can be due to loss of muscle mass as we age. And sort of by definition, very frequently they have impaired renal function, and more advanced kidney disease. And we know that it significantly increases their risk of bleeding as well as their risk of stroke. And as far as the less antiplatelet therapy, it just may be due to some of the criteria for the trial that as they were older, these patients may have been less likely to have concomitant coronary disease. As because they sort of just got to be older, they didn't have they had atrial fibrillation, but they weren't on antiplatelet therapy because they haven't had a prior heart attack. So that was really fascinating. If you plot age on the x-axis, normally what you see with rivaroxaban, you see this for all the other DOACs as warfarin, is as patients get older, starting in their 50s, 60s, 70s, 80s, 90s, the bleeding risk just goes up literally over time. And what was really remarkable when you look at both abelacimab doses and we looked at it pooled as well, that it's really flat. That you have this low level of bleeding and essentially stays there, even in patients who are 80 years of old, 90 years of age. And so, that's really important because I think we start to worry more about lifelong anticoagulation in the elderly. We're often not starting it in those patients when they have atrial fibrillation. We're discontinuing it as they get to be 75, 80. They have other comorbidities. And this shows that really, as patients age, they're not accruing additional risk of bleeding with abelacimab. And when we look at the results, both in patients who are 75 and above, or 80, 85 and above, what we see is those still same dramatic relative reductions in bleeding, talking 60, 70, 80%. So really substantial bleeding. But because patients who are older have higher absolute rates of bleeding, right? They're at higher risk because they're older, they have impaired renal function, et cetera. You see more dramatic absolute reductions. So we're talking about several percent of patients per year who will have less both severe bleeds and less minor bleeds and bruising if they're treated with the factor 11 inhibitor abelacimab versus rivaroxaban. And this provides, I think, enormous comfort to patients that if this drug is approved and it's in late stage phase 3 trials, it may be a really attractive alternative, particularly for elderly patients who have this higher rate of bleeding. That this is a remarkably safe drug, and that even as they age, they will do so without accruing additional bleeding risk. Great question, and this is certainly one of the big challenges that we face in clinical practice, not just my practice, but I think every practice throughout the world. We know, and there are various registries that show the same thing, somewhere between 30 to 50% in some studies of patients who have atrial fibrillation either are not started on an anticoagulant or discontinue one. And the primary reason for that, as you noted, is they bled before or they have a fear of bleeding. And so one of the challenges to talk to patients is that our current level of anticoagulation, although our standard of care, although the rates of serious bleeding with the DOACs is less than warfarin, there's still a lot of bleeding, gastrointestinal bleeding, bruising, and that's a big issue for patients and their providers. I try to counsel patients two things. One, that we certainly do care about bleeding, but we really also care about reducing stroke in these populations because we know even the drugs we have are very effective. They reduce stroke by 70 to 80%. And strokes off anticoagulation due to atrial fibrillation are more likely to be fatal, maybe 25, 30% are fatal. And the majority of patients who survive have some neurologic disability, maybe even the inability to live independently. And so we may tolerate a risk of bleeding because those strokes are so devastating. And there certainly are things we can do to lower patients' bleeding risk, and we have to be more proactive about that. If they're also on antiplatelet therapy, aspirin, Plavix, etc., maybe those could be discontinued, and we become a lot more aggressive about, hey, you don't need to be on that aspirin anymore. How much nonsteroidal anti-inflammatories are you taking for your arthritis? Maybe cut back if you can. Limit alcohol intake. Those things better control your blood pressure. By modifying all those things, we can substantially lower patients' bleeding risk. So I think it's like we do care about bleeding. We want to do everything we can to minimize that risk. But remember, we're giving you a blood thinner and anticoagulant because we want to prevent these devastating strokes. But that is an important conversation to have, but it's difficult. What will make that conversation even easier, though, is if we could say, and we have a drug that's associated with 60, 70, 80% less bleeding than anything you've used before. And I think if we could bring down those rates of bleeding to levels that we've never seen with an anticoagulant, that will really improve our ability to manage even our most vulnerable patients, those who currently are not even treated with our standard of care anticoagulants. Yeah, it's a great question. I mean, there are a couple of parts to that. One, due to that it's a monoclonal antibody, there are some attractive features of it. One, uh, we expect compliance to be better, right? Because we know that patients often miss doses, particularly with twice daily, but still with once daily. So having taking it once a month, longer duration of action should improve the coverage for patients, that there'll be less missed doses, less periods of time where they're not protected. So that's potentially a benefit. There are also no renal clearance to this drug and no drug-drug interactions. So all the currently available oral therapies or even the oral factor 11 inhibitors that are being developed, there's some degree of renal clearance and there are potential drug interactions. So this kind of avoids all of that. One of the things that you mentioned is there's a longer duration of action, and we know with our current anticoagulants, there's a lot of stopping and starting anticoagulation, say in and around procedures, because of bleeding risk. So one concern as we were helping develop Abelacimab was that, well, what are you going to do with a long-acting drug, when patients are having procedure? And in another important analysis that we did, we looked at patients having procedures. And interestingly, the bleeding is so low with Abelacimab that many patients had bleeding on Abelacimab, and their rates of bleeding were very low. In fact, comparable to a strategy of what we do with rivaroxaban in the trial, which is stop 24 to 48 hours usually before a procedure. But so I think abelacimab and maybe factor 11 inhibition in general is so safe, that we don't really need to start and stop these drugs like we did before. Just like if you're on a statin, you don't start and stop the statin for every procedure. I think we may get to that day with these longer acting factor 11 inhibitors. And I think it is an injection. It's a subcutaneous. It will be ultimately when it's developed, a subcutaneous injection, when if it gets approved in the market. And I will say one of the things in cardiology, given other therapies that we're using commonly, PCSK9 inhibitors, the weight loss drugs, the GLP-1 receptor agonists, we've become a lot more comfortable giving subcutaneous injections. And the fact that it's a less of a pill burden, compliance is better. We think that there's certainly an important role and maybe even an attractive benefit of having these long acting agents, and this one given once a month subcutaneously, if approved.